Hi, everyone. Jonathon Leipsic coming to virtually 6 a.m. here in Vancouver. I'm honored to be here as moderator of this great JSCAI session dialogue with two luminaries in the field. I serve as a professor of medicine and radiology at University of British Columbia, but my role here today, as mentioned, is moderator of this discussion. We're going to be focusing on a recently published special issue on the role of coronary computed tomography, or in fact, cardiac computed tomography in cardiovascular risk stratification, diagnosis, treatment, and prognosis of coronary disease. We're really fortunate to have two amazing thought leaders in this space. And I say they're real thought leaders because of their vision. They're interventional cardiologists and active in their role as interventionalists, but they've really, over the years, integrated CT into their practice, helping us all understand the potential role of CT to plan structural interventions and to plan coronary interventions alike. To that end, Dr. Tej Sheth, he's the cath lab director and TAVR lead at McMaster University, has integrated CT and helped lead the integration of CT into the structural and coronary space from an interventional perspective, really for the better part of 2 decades. And it's really great to have you, Tej, with us today. And then Dr. Abdul Ihdayhid, who's an interventional cardiologist and cardiac CT reader and specialist in academic space and coronary CT at the Harry Perkins Institute of Medical Research, clinical senior lecturer at the School of Medicine at the University of Western Australia in Perth. So I really want to thank you both for finding the time. As you know, this JSCAI edition is one that I'm personally very excited about, and I think the field will be very glad and excited to have the opportunity to reflect on and learn from. To that end, there are 2 papers that I was hoping we would highlight today, and we'll start with you, Abdul, if we could. And this is the rationale and design paper for the Future AS Registry, Feasibility and Utility of Anatomical and Physiological Evaluation of Coronary Disease with Cardiac CT in Severe AS. So I'll hand it over to you, Abdul, to share a couple of thoughts, and maybe Tej and I can ask you a couple of questions about this work.
Yeah, no, thank you very much, Jonathon, for the kind introduction and for the opportunity to share this podium with you. So look, the rationale for what we're doing here is we're trying to find a better way to diagnose and evaluate coronary artery disease in patients undergoing TAVI. Coronary artery disease assessment is really an essential part of the heart team discussion as we risk stratify patients who are being considered for TAVI. And traditionally, in many parts of the world, there has been as part of that journey is an invasive angiogram. And, an invasive angiogram is would be still a costly procedure. It adds to the waiting list time, or as we increasingly say, time to valve, and which can be associated with adverse outcomes. And what subsequent data has become quite clear is that no matter how much we look, no matter how much we keep looking for coronary artery disease with invasive angiography prior to TAVI, we're not revascularizing the majority of these patients. And so, it naturally comes about as like, could we do this differently? And there have been some groups that have just used the TAVR CT to look at the coronaries as best as they can. Just taking the TAVR CT and seeing if they can see the left main and the proximal LAD and leaving it at that. But as we're moving towards younger patients and patients where the lifetime risk for developing significant coronary artery disease and the implications of what their baseline coronary artery disease has on the valve choice and the ability to recannulate the coronary arteries is important, characterizing that coronary artery disease is increasingly becoming relevant. And so one of the biggest limitations, for the TAVR CT has been this reluctance to optimize the image quality. Right now, you wouldn't do a cardiac CT without optimizing it, with GT to dilate the arteries or giving beta blockers to slow down the heart rate to avoid motion artifact and to give you image quality that would allow you to assess the stenosis and the presence and the burden of coronary atherosclerosis. Yet for TAVR CT, we don't do that. And that has been due to a historical reluctance or concern that GTN is very dangerous in aortic stenosis. Now, if we go down the rabbit hole, there actually haven't been any studies that have shown any major sort of concern with aortic GTN and aortic stenosis, and that's because there's been the absence of those studies. So we've built on some pilot work that we did during my time at Monash Heart in Melbourne, Australia, led by Dr. Brian Coe, one of my mentors and PhD supervisors, where we gave GTN in around 30 patients with severe aortic stenosis, and we found that actually it was well tolerated. Now, it was a small study, but we wanted to reevaluate now what would be the safety, the feasibility, and the accuracy of properly optimizing TAVR-CT to assess the coronary arteries, and then subsequently also consider its utility with FFRCT. So that's the overall premise for the study. I'll stop there and sort of open it up for any questions and discussions from yourself, Jonathan and Tej.
No, thank you. I mean, I'm curious to also get Tej's thoughts, because obviously I'm intrinsically or involved in the study and had really watched your work from Monash and seen additional work, Abdul, as it relates to the more complete evaluation of coronary disease from CT from people like Amit Pursanani, as you know, from North Shore and Evanston, and two recent accuracy studies that have come from Japan exploring that. So one thing that I would like to ask you is, when I reflect on this work, a lot of people talk to me and they ask me about the role of hyperemic physiology in aortic stenosis and the challenges with achieving hyperemia in aortic stenosis. And what I try to reflect on with them is my understanding is your goal with such an analysis is not so much accuracy for physiology, but more robust initial assessment of the extent of coronary disease to inform the likelihood of leaving disease behind and coronary reaccess. Is that the sort of right way to think of it? I mean, obviously, you need to rely on the tool non-invasively to have some degree of discriminatory ability. But to me, it strikes me as less about an absolute cut point, but more as a continuous variable, which we've learned from invasive physiology broadly, even in other populations. But maybe just some thoughts on that.
So look, I agree with you, Jonathan. I think that, yes, there are the way that we think about physiology and aortic stenosis has, sometimes there has been an emphasis that maybe we don't achieve full maximal hyperemia, particularly when there's in the presence of significant left ventricular hypertrophy. It's probably most relevant around the gray zone lesions where invasively, if we measured an FFR, we may potentially underestimate the severity of a lesion because we might not achieve maximal hyperemia. However, if we were simulating FFR with FFRCT, we're probably seeing a more true reflection of what the underlying physiology of that lesion would be in the absence of aortic stenosis or once the aortic stenosis has been resolved. And so that does give you a better understanding about what the lifetime planning of that lesion is in the context of, okay, well, I've got a lesion here that's, say, 50% in the proximal LAD. It's 0.76 on FFRCT. What does that mean for the patient here in front of me who's 85, maybe not so relevant, 70, maybe a bit more relevant? And so I do think that it does provide insight. I think that, I think to your second point, probably the more overarching benefit of characterizing the coronary artery disease is understanding, one, the immediate need for potential revascularization post-TAVI, and so that can dictate what your valve choice would be. You might choose a lower frame design or a frame design with large cells. But increasingly, we're seeing in the data that actually post-TAVR revascularization, as in i.e. within the next 12 months, is quite low. So the incidence of actually needing urgent revascularization for symptomatic angina or even, is quite low. And the vast majority of patients get excellent symptomatic benefit from just treating the aortic stenosis. However, to me, the more important question is that if I'm putting this into a young patient who's maybe got another 20 years ahead of them, what's their lifetime risk now for myocardial infarction? And to try and do a STEMI or to try and do a non-STEMI, everyone who that's done, you're at Tej, you're an interventional cardiologist, you do a STEMI and you see a supraannular tall frame with small cells, you know that you're in for a long night, like potentially. And data's come out that suggests that patients who have a tall frame small cell valve and who have a myocardial infarction have up to 30% failed PCI rates, which we don't see that in primary PCI, and have worse outcomes and longer door to balloon time. So I think that's they're the considerations that would come into a heart team discussion. To put it practically, if I had a 70 or a 65-year-old male who had diffuse coronary atherosclerosis, maybe mild to moderate disease in the proximal LAD, some further disease in the right, thinking, well, maybe this patient might have progressive disease as they get older. I might be more inclined to put a valve type that'd be easier to recannulate the artery. So I hope that's answered that.
That's really helpful. And Tej, I mean, your thoughts?
Yeah, just first a comment on, I think there is different approaches within the field in how patients access TAVR or aortic valve programs. Let me just say that. And I think in many programs, invasive angiography is the gateway to the cath lab. And I think, going down the pathway that you've advocated, where we look at the coronaries on CT, I think requires interventional cardiologists, surgeons, everybody involved in the valve team to put the CT at the start of the workup pathway. I think that's something we should just acknowledge. Something we've done at our center. We completely agree that CT should be used as the first line modality to stratify patients for coronary disease. But I just want to point out that in many centers, access to aortic valve treatment seems to still flow through an invasive pathway. And those patients may end up having multiple invasive procedures that could be avoided if we did CT first. We've published on our experience of just doing CT coronary evaluation in a non-gated CT. So one of the things I would highlight, Abdul, is that actually in younger patients, the concomitant presence of coronary disease is relatively low. So probably about 70% of patients will have either minimal or no calcium. And even in a not so great coronary evaluation on a TAVR CT, we can pretty much clear them to focus only on the aortic valve and not worry so much about the coronaries. But I think you highlight a subgroup of patients in which there is a presence of coronary disease and we're not able to assess the quality. And I would want to ask you, in your routine TAVR practice, is it now the case that all of your TAVR CTs are having nitro and beta blocker to optimize the scan, or is it something you do selectively based on certain workflow? Because I'll tell you, in our center, we do 1,000 TAVR CTs a year now. So it's a very large volume. And our workflow currently is not to do the nitro and beta blocker just because of, a variety of logistical concerns within the department. And it's probably a question you'll get from a lot of people who do these imaging protocols. Interested in your thoughts on that.
So thanks for the question, Ted. And you raise a very good point about the burden of disease is certainly much less in younger patients, which actually increases the rationale even more for doing this non-invasively, because the value of doing CT would be less. And I think before I answer your second point, I think it's important to highlight that the discharge trial, and for the people listening here, the discharge trial was a really pivotal trial, pragmatic randomized trial that came out of Denmark, looking at unstable coronary artery disease, randomizing a strategy where you went for a cath versus CT to evaluate the coronaries. Essentially, using a strategy to guide management, there was no difference in outcomes, but there was a significant difference in procedural complications. So highlighting that invasive angiography is not benign. And this was in a cohort where the average age was around 50 to 60, yet in many of our cohorts, they're much older, where the risk of complication is higher. So it's sometimes we think of it as a benign, simple, just procedure, but the complications do happen. To your second point about routine practice, without going too much into the results, what we've shown so far, which we hope to share later this year, but we've been really reassured with the safety overall with giving GTN. We have taken a conservative approach for the study. The study excluded those with critical aortic stenosis. We felt that those with really critical hemodynamics, I think we don't want to push the boundary too far just yet, so we avoided GTN those. Those with recent compensated heart failure, those with recent, syncope, and would be and those with a poor ejection fraction less than 30%. One other cohort that we didn't include in the study, but I think that would be important to highlight to the audience, with those with underlying right ventricular dysfunction. So I think the RV is the often forgotten ventricle, and it's very preload dependent. And so giving vasodilatation with nitrates, or slowing down the heart rate, with the RV being a heart rate dependent ventricle, could potentially be associated with maybe an adverse event following the medications. But in general, we're excited to share our data later this year. But I think we're going to see the signals. It's pretty good. So in our practice here at Fiona Stanley Hospital, we have gone more routinely in that select cohort to give GTN. What we found by trying to be more thoughtful with giving beta blocking and GTN is that the quality of our annular assessments is much nicer as well. We're getting much crisper analysis. We're not getting that sort of disco looking annulus where we're not sure where the edges are. It's increased the quality of the overall assessment.
I'll close this that section with that comment. I think that's really important. I think, though, it's that balance, right? It's exactly as you suggest, Tej. Like, how do we scale it? How do we appropriately optimize the image quality when need be? But I also highlight your point that, a lot of patients are still coming into our centers, having undergone angiography, and how do we come upstream of that and really try to streamline that assessment? So thank you for that great discussion. Let's pivot to you now, Tej, and your manuscript that's being highlighted here in JSCAI. It's obviously got a different focus, an important one, though, reflecting on where we're at with gated CT evaluation of the aortic root for planning of patients with aortic stenosis. So, Tej, please.
Yeah, thanks, Jonathan. And I think I want to highlight one change in terminology that you'll notice in the title of this paper, which is that we've talked about gated cardiac CT or coronary CT for the assessment of the aortic root for aortic stenosis. And we've gotten away from the terminology of TAVR CT, which actually many of us still use, because I think the reality is in 2024, all patients with aortic stenosis need a CT evaluation for therapy planning. And so what we've done in our center is we've adopted a centralized pathway and intake where everybody with aortic stenosis has a CT scan, and this would be a 50-year-old who might be having a Ross procedure all the way up to a very elderly patient who's obviously not a surgical candidate. But everybody has the CT evaluation, and then we have a heart team review. Actually, we do it, to be honest, in the CT department. So there's a surgeon and a interventional cardiologist who, right after the CT is acquired, we review the images, we have a thorough understanding of the anatomy, and then we actually consult with the patient to dictate therapy. And so through that, and I just mentioned earlier, our program has grown over the years, and we're doing a very large volume of CT imaging now for aortic stenosis. So that has given us some insights into the kind of anatomic pathology that we see, across the age range, and some of the considerations that we've applied in our own practice in selecting patients for either TAVR or a surgical approach. And Jonathan, you've done, so much of the early work in this space to define how we can measure the annulus, how do we select different valve therapies. This builds on that, I would say, in that what we're trying to do is say, okay, we do have a robust therapy of TAVR. We have an equally robust therapy of SAVR. What are some of the considerations beyond simply annular sizing that we can think about that will choose or help us to dictate whether we do TAVR, SAVR, or even different valve types? So that's really the theme behind the review. And as you can see on the slide, there are several areas of aortic root assessment that we focused on in the discussion that included the assessment of annular and LVOT calcium, excessive leaflet calcium, different anatomic configurations at the sinotubular junction. We had a discussion about bicuspid valves because that's a unique population, which, by the way, in our center, if you have a bicuspid valve, you're actually more likely to have TAVR than SAVR, provided you don't have another indication for surgery. So we're very comfortable treating many bicuspid valves, but there are certain bicuspid valves that really would benefit from surgical intervention. And this article helps to highlight some of the considerations that could arbitrate that decision. And then we also look at coronary risk and then the extremes of annular sizing. So that's really what the review is. It's meant really for operators who are either surgeons or interventionalists who want to get a greater feel for some of the considerations that one would need to have in making these decisions over time.
Thank you. That's great overview. I really enjoyed reading your manuscript. I really like, Tej, and you've highlighted this in this discussion, how you went upstream. And I think it was great how you focused on the purposeful word selection in the title, right? It's not, the second you say TAVR CT, you put your blinders on, right? Instead of going upstream and saying, hey, we have a patient with, whatever the case is. And it reflects also in the review, aortic size, aortic geometry, all of these things that play a role. And you mentioned about bicuspid valve morphology and the role that CT plays to adjudicate the sort of TAVR-related risk. This is something that obviously we've seen a lot of work from Cedars. You mentioned that you're doing a lot of bicuspids. Are you still? Is it largely the raphe calcification and the extent of the leaflet calcification that's determining surgical intervention then, or is it a combination of that and age, or How are you making that decision now to a greater extent in McMaster?
Yeah, so once we exclude patients with aortopathy or other surgical indication, and it's really just a question of the aortic valve, then we actually look at a combination of those factors. So what we've seen in our experience is that even patients with fairly high burden of leaflet and raphe calcification, both raphe and the contralateral leaflet in the common Sieverts-1 left-right fusion kind of pattern, can still be treated with TAVR provided the sinus dimensions are large and the intercommensural distances are adequate. And that pertains, most of our experience in this anatomy is with a balloon expandable valves, because you do need really good radial strength in order to get a good expansion. I will say that we've done, actually in collaboration with your center and several other Canadian centers, a paper, and then this paper is just about to come out, a study where we did follow-up CT on 100 patients after we implanted the bicuspid valve. Because one of the questions is, yeah, you can get the bicuspid valve treated safely, but what does the stent geometry actually look like? And have you set the groundwork for a repeat intervention in the future? Or have you simply put a deformed stent that works okay for now, but may run into problems in the future? We were surprised to see within that cohort that calcium itself does not predict stent expansion or ellipticity. It's more about the shape of the aortic route in which you're implanting. So I think that's a very important consideration as well.
That's fascinating. I look forward to that work. I think that's really important to keep in mind. As you mentioned, this is why I could never do interventional cardiology, because you're always balancing between, you need enough radial force, but not too much radial force. But I think you highlight a really important point, Tej, is the perforations, in the bicuspids that we saw in the early days often were exactly to your point, like almost like a stalactite going right through the sinus, not at the annular level, but really it's at the sinus, right? So
absolutely. And I would say our clinical experience, understanding the relationship between sinus dimensions and geometry with planned valve size and the load of calcium on the leaflets has been crucial. And, a very nice, I'll call out, I think it was the Bavard Registry, where they helped us to understand the different patterns of supraannular anatomy within the bicuspid patient. And these variabilities really do exist. I mean, the tapered supraannular anatomy does occur in about 5-10% of patients. And that is the one that you really want to avoid. And when you show a case like that to a surgeon, like, oh, this is straightforward. We'll just take the root out, we'll do a valve out, we'll do a root enlargement. That patient's going to have a safe and robust surgery. And, we certainly look at our local outcomes, both for TAVR and SAVR, but as well published from many other centers, contemporary low-risk patients are low risk for both. We saw that in PARTNER 3. I mean, I think everybody would have looked at that data and said, there's excellent TAVR results and excellent SAVR results. So when we look at an individual patient, I think we really have to be thoughtful. Yes, we can offer you TAVR, but we have to make sure that TAVR is going to perform at the level of contemporary low-risk surgery.
Just get your thoughts in just a moment, Abdul, but I will say I think that's so important. You've highlighted something that I shared after the PARTNER data was published in our core lab experience, just really highlighting that, to your point, it's no longer about, it's how you define low risk, I think, Tej. And I think what you're showing in this paper is that in TAVR, surgical risk is only a modest predictor, obviously, of TAVR outcomes. The stronger predictor are a lot of these anatomical findings that, in fact, can be identified on CT. And maybe, Abdul, I'll let you have a closing comment about your thoughts on this great review, and we can bring this discussion to a close.
No, thanks, Jonathon. Look, I just had actually two questions, Tej, because I thought that was it was a great paper, and I just wanted to see what one locally we've been having this debate at the moment. Our heart team discussion is just for TAVR. We never see the surgeons' decisions about SAVR. They send us the patients that they've rejected, and this idea that actually it's about what's the best treatment for aortic stenosis, I think is a great way to put it, and hats off to the way that you presented that. Because I do think that that's what the heart team should be about. The second question I have is, how much lifetime planning is now being part of your heart team discussions? I saw that in one of your pictures, you had a semi-simulation about how a valve would sit. How much does that play into how you decide SAVR versus TAVR versus valve type? Do you do it for every patient? Do you do it just for young patients?
Two great questions. The first, I would say, I would advocate that in every center, we try to achieve this kind of a pathway where all patients with aortic stenosis are considered not just the TAVR rejects or the surgical rejects. Because there are some younger patients who are very well served with the transcatheter solution. And that's what, let's face it, that's what most patients want if it's feasible to provide. So I think as a center, it's important that, each one try. There's a lot of politics and challenges involved in implementing that. I can attest from my own experience, but it's a very patient-centered way to go about doing it. And I think when you have that context, you have both a surgeon and an interventionist who are engaged in the imaging review. The second question that you asked is a very natural one to answer, because you're able to look and say, okay, I'd like to have a lifetime approach. What can TAVR offer? What can surgery offer? And I'll tell you, sometimes putting the largest prosthesis in with a surgical approach without sinus or root enlargement is not actually the way to go. You may actually reduce the potential repeatability of the TAVR by causing very small VTCs and the post-TAVR CTs. We've actually done some post-TAVR follow-up imaging post-surgical follow-up imaging with CT, and we see this phenomenon where a large prosthesis done with a root but without a sinus enlargement actually leads to quite a bit of crowding at the level of the coronary. So, I think there has to be a nuanced discussion both between the surgeons and the interventionists in those cases.
Yeah, that's really a great discussion and a great vision implemented already at McMaster. Source of pride for me as a fellow Canadian, and I think something that we can all reflect on and try to do better for our patients going forward. I'll thank you both. I'll just wrap us up. Thank you both for the time, for the insight, and the really great work. And I would just advocate that all the listeners and readers take a look at the journal. It's a great edition. There's a lot of interesting learning there, some original science, some great reviews. And I personally look forward to reflecting on it again and continuing to learn with both of my colleagues and the field. Thank you again, friends.